Okay, good morning. Good morning, everyone, and thank you, Mike, for that introduction. It's a pleasure to be here and have the opportunity of this presentation and then this conversation with all of you. So thanks, Mike. Thanks, Liz, for the opportunity. And greetings and welcome to all of you colleagues from Ethiopia, Ghana, Liberia, Mexico, Rwanda, and Singapore, and thank you for coming. So I was asked to speak somehow broadly about global health leadership, and I'll try and do so from the perspective that somehow Mike indicated of being a physician, a scientist, having been what people call a global health diplomat as an ambassador, and then for the last 2 years as executive director of the Global Fund to fight AIDS, TB, and malaria. And as you know, since it was established back in 2002, that is only 7 years ago, the Global Fund has become the primary multilateral funder in the fight against these 3 diseases that still kill over 4 million people in the developing world each year. So there are many ways I could speak about leadership and many sort of qualities I would see for leaders. I've been thinking about it as I was preparing for this talk. And some of the key words that came to my mind were courage, commitment, accountability, ability to express a vision that inspires people, but also making decisions and dealing confidently with their consequences, empathy, inclusiveness, admitting and learning from lessons, capacity to listen, and perhaps, above all, and particularly in hard times such as these, as we go through the financial and economic crisis, I think the capacity to remain hopeful, even if in difficult times. Because when you talk about global health and public health, you talk about bringing hope to people. Leadership, of course, takes place in many places, in governments, in institutions, in business, in households, and of course in universities. I come myself from academia. I have been teaching at the university in Paris until like 2 years ago, and I really think that whatever the domestic or political environment, universities since maybe the 13th century, have always offered creative leadership for their countries. And so I do welcome very much the initiative of this program, and my best wishes to this new program you're just launching. So I can't sort of cover all of these themes in 45 minutes or whatever the time here. So I thought I would focus on 3 areas. First, I'd like to give some personal reflections on how I came to be where I am today, and what it is that I should have somehow the audacity of speaking to you about leadership. And I'd like to touch on some lessons in leadership that came to me, in between the time when I started as a young clinical immunologist in the first years of the AIDS epidemic to now. Secondly, I'd like to speak about the AIDS epidemic and about the leadership of the epidemic. And because that epidemic not only has led us to where we are today in global health, but in fact has profoundly impacted on the development agenda and has really helped put health, global health, at the forefront of the development agenda. And third, maybe I'll like to take a few minutes to speak about the challenges I see, the key challenges I see for global health, and therefore to the health leaders that you are in your different roles and different places where you work, to make sure that the health maintains its place in difficult times, as I was saying, as a leader in the development field and as a leader in human endeavor. So let me go back a few years. Of course, you know, my own story is not necessarily a pattern for leadership that I would recommend to others. But as I think about it, I sort of wrote down 4 key turning points in my career as a physician and as a scientist to highlight some of the lessons and then that I believe has served me subsequently in different leadership roles. I actually first started university as a student in Latin and philosophy at the Sorbonne in Paris. And then I sort of hesitated, and I hesitated between going into medicine or into political science. Actually, I was sort of pairing with a student, a close friend of mine, who went into political science and actually ended up as, the vice chair of the French Parliament now. But I went into medicine. I went into medicine because obviously I was persuaded that that was the best way to serve people and to contribute to society. And remember, that was in the mid-70s, and this was a time when immunology, which is the area where I specialize, was a sort of booming specialty. But it was these were booming areas for medicine. The first transplants, heart surgery, nothing seemed impossible to medicine somehow. There was a profound conviction that science and medicine, technology, will be able to solve all of the problems we were facing. So I did master's and thesis in parallel with my medical studies, and then I completed some postdocs, very different postdocs. One in England at St. Mary's Hospital, Paddington in London, where I really learned about being curious, raising questions, the way the British can do. Most of the conversations about what an antibody molecule is, took place at the pub. But that was not the place to really learn how you actually do science, how you ask the questions, how you learn about the methods, how you learn about reasoning, putting forward a hypothesis, a deductive reasoning. And in those days, I'm saying in those days because I think now Europe has more than caught up with this, but in those days, these are the things you really needed to come to the US to learn. And so I did spend close to 4 years actually here. Here, in the other university. Let's say in Cambridge, Massachusetts. So that period as a young academic, has taught me lots of things. How to generate a question, how to design a protocol, how to collect and analyze data. And that, I'd like to say, is the first lesson learning about how to gather and use evidence, because evidence is the most powerful base, the most powerful tool for action. It's the most powerful tool for advocacy. It's the most powerful tool for leadership, evidence. And actually my mentor at Harvard, Professor K. Frank Austin, at that time a renowned immunologist, used to say, Michel, first get the data and then write the editorials. and this is something I will remember. Now the second turning point occurred when I actually returned to Paris. I worked as a physician and a researcher in the area of immunologically mediated renal diseases. That was quite a booming area of medicine. Renal disease and maybe also hematology were the two areas where immunology was bringing a lot about pathogenesis, mechanisms involved, and hope in the future of innovative therapeutic approaches. This was just about the time when AIDS was being identified as a new disease. So that period came first initially as a fascinating, either somehow thrilling time to a young immunologist. For those of you who know a bit about immunology, and this was the time when this was a time in Yale where when Charles Janway was doing some of his pioneer work, but this is an extraordinary time of accumulation of knowledge, and knowledge that was bringing hope for very innovative approaches to diseases. And what happened with AIDS, of course, is that these first months and these first years of fascination somehow rapidly turned to a quite different mood, and a mood of despair. The first tests for HIV became available in 1984, and testing blood donors for HIV became, or what was passed as a law in July 1985 in my country. I was at that time working in a university hospital called Hôpital Broussais. Broussais used to be the surgeon of Napoleon. And that happened to be the largest hospital for cardiac surgery in France, where the first heart transplant was performed. And therefore, that hospital had the largest blood bank in Paris. And because of that, it had also the largest absolute number of people detected as, at that time it was called LAV, positive serum. In addition to what, that blood bank was collecting blood from the very center of Paris. It was a fairly central facility. So for all of these reasons, many people happened to be detected as positive for that virus that was identified now 83, as you know, and for which we really didn't know what the pattern of the disease would be and what we should tell to patients. We were, in those days, very much in a sort of hepatitis model, thinking that perhaps some of the patients would do well for many years, whereas some others would evolve. But then, very soon, so that's the second half of the 80s, we could see what the devastation of AIDS is, what it was at that time. and so the second lesson is that, you know, when comparing with learning about the power of medicine and technology and the power of scientific evidence, you know, I learned a second lesson, and that lesson was about humility and about the limits of medicine. And these were extremely frustrating years. Not only frustrating from a human perspective, you know, facing the suffering, the isolation of the patients, but to bring it back to my first lesson somehow, these were very frustrating times for a scientist and for many of us, because for a physician or for a scientist, I think there's nothing more frustrating than not understanding. Because not understanding means not helping. So I went through those years, the second half of the 80s, as an AIDS physician, with more and more patients, with people dying in the ward every day, in the total, you know, years of total frustration, death, and despair. These were also the years where, you know, trained as I said, as an immunologist or a renal physician, I was used to medicine being a sort of, you know, being around reasoning, being around the deductive process. I don't know whether some of you have been doing renal medicine or hematology, but it's really reading, you know, the results of blood tests, urine tests, and reasoning from that. It's not an area of medicine where you actually get physically in contact with the wounds somehow of people. And AIDS, that is the prototype of immune deficiencies, of course changed all of that, because patients in those days particularly were coming with advanced disease and with all of the symptoms, you know, Kaposi's sarcoma, mycosis in the mouth, pneumocystis pneumonia, cytomegalovirus disease in the eyes, dementia, and so on. And as if that was not, you know, enough, AIDS was also progressively more and more coming as a social distress, with drug use, marginalization, discrimination, homophobia, and association with poverty. And as a result, you know, I think AIDS taught me what I would call the third lesson here that I'd like to leave with you, which is to focus on the whole person and not just on the manifestations of disease or on disease. Remember the definition that the World Health Organization is giving of health, which is so much broader than just physical health. It's about physical, mental, and social health. And so it taught me, and it taught thousands of physicians around the world, a fundamentally different paradigm about the relationship between the doctor and the patient. These were years where the power of the doctor, what the philosopher Michel Foucault called the asymmetric relationship between the one who actually detains the power because he detains the knowledge, and the one who confronts with the power, the patient. That relation was completely changed. I actually recently, as I was speaking at the International Harm Reduction Conference in Bangkok, and I spoke about a patient whom I remember and who I think was a leader. I'll come back to that. To me, patients are leaders. he was called Nestor, and he was infected through drug use and sharing needles. He lost his brother to AIDS, he lost his sister to AIDS, he died of AIDS in the early 90s. And in the very first days of the epidemic, I think in the, somewhere in the mid-80s or early in the second half of the 80s, we had very few tests, and I sort of said to him, okay, Nestor, we're doing well, I'll see you maybe in 3 months' time, and I would like you to come back with what we call now a CD4 cell count. At that time, we didn't call the cells CD4 yet. And he said, why? Well, I said, to follow progress somehow. And he said to me, I don't expect you to follow. I expect you to anticipate. Okay? And so this is the sort of lessons you learned. And I think by expressing their needs so freely, by learning about treatment options in those days more rapidly than doctors somehow, I think the patients became leaders themselves in a way that I think we didn't know before AIDS. And so that's another lesson, and a new, I think a totally new paradigm. It took then the world many years before it recognized the extent of the AIDS epidemic in the developing world. Although my colleague and close friend, Françoise Barré-Sinoussi, Nobel laureate this year, had shown in 1985 heterosexual transmission of HIV in Cameroon and in actually several other countries in Central Africa, but didn't take until the 90s and the late 90s before the world somehow acknowledged and recognized the disaster of AIDS in the developing world. And it took until the late 90s and the early 2000s really for the world to actually begin to seriously act to rectify the emerging inequities in the response to AIDS between the North and the South. At that time, so I'm now jumping a few years, end of the 90s and early 2000s, I had the privilege of being the director of the National Agency for AIDS Research in France, called the ANRS, which is the large and actually the second largest, research entity on AIDS after the US, with smaller, of course, much smaller budgets, but I was actually strongly determined to reorient the work of that agency, and starting from 1998. 1998, you may remember, or some of you may remember, was the ICASA, the African Conference on AIDS, that took place in Abidjan, Côte d'Ivoire. And in that conference, Bernard Kouchner, the founder of MSF, said that the patients are in the South and the drugs are in the North. I think a very powerful way of talking about the inequities in this world. And President Chirac called for the first time for treatment of AIDS in the developing world, something no one would think, to consider in any other way than just an impossible dream at that time. In 1998, I sort of reoriented the agency so that actually up to a third or over a third of its budget was directed towards medical research, clinical research, but also social science research on the AIDS epidemic in developing countries. And these were great days. These were days where some of the first trials took place. The trial on whether Bactrim is prophylactic in the setting of AIDS in the developing world. The first trials, AZT trials, to prevent mother-to-child transmission of the virus in Abidjan, setting in 1999 the first cohort of patients on treatment, on antiretroviral treatment in Senegal. Senegal was the first country in Africa to start a national program on AIDS. Then looking at the efficacy, the tolerance of the first fixed dose combination of generic drugs, Triomune, that was 2003. Later, and as we were entering in the early 2000s, results from all these studies and a number of studies, now the evidence was coming to actually help build the advocacy for the demand for access to treatment in the global south. Remember what I said about evidence as the fundamental basis for advocacy and for leadership. In 2001, people had, and I actually had a slide on that, they had many reasons to say that scaling up access to treatment for AIDS in the developing world was just impossible. It was impossible because the drugs, people were saying, are too expensive. In 2000, a first-line drug regimen for AIDS costed $10,000 per patient per year. The lowest price we're now paying at the Global Fund for a first-line regimen is $92 per patient per year. Okay, people were saying we don't know whether patients will take the treatment, whether they will be, as we call it, adherent to treatment, whether they will tolerate the treatment, whether the treatment will be effective in resource-limited settings, and all the evidence accumulated in the early 2000s that not only are patients adherent to treatment in the developing world in the cohorts, but actually they're even more, they show better adherence than the cohorts in the north. And there is now ample evidence, about the effectiveness of the treatment, even in some of the poorest settings. People are saying, we're saying treatment is not cost effective. There's now evidence that AIDS treatment is actually one of the most cost-effective interventions we have had in medicine, much more cost-effective than treating myocardial infarction when it comes to lives saved. And not speaking of preventing mother-to-child transmission of HIV, which is an intervention of which the cost is around $15 US. People were saying that if we hurry too much in disseminating treatment in the South, treatment will not be taken appropriately, and we will generate resistance, and there will be a sort of second wave, epidemic of resistant HIV. And I heard, actually, I'm sorry to say, Professors Gallo and Montagnier, claim such, I think, unacceptable statements, 2003, 2004. And of course, that doesn't hold true. Actually, there is less resistance currently in what we know from the cohorts in the South than what we see in the North. So these were extraordinary years of sort of hope about where we could be. And there are a number of people, a number of leaders, of people whom I'd just like to mention that I think have been my heroes in those days, and I would like them to inspire you somehow in this leadership discussion. Christine Cafondo, she is a woman living with HIV in Burkina Faso, and she was one of the first women to come up and talk about her being seropositive, and she actually appeared on placards all over Burkina Faso on the roads, together with President Compaoré. Danielle Defer was actually the partner, the lover of philosopher Michel Foucault, who died of AIDS in the early 90s, and he was the founder of one of the sort of leading NGO against AIDS in my country, called ED. Together with Danielle Defer, we, in the late 80s, opened something that I'm actually proud of, which is what I called la consultation du soir, the night clinic. These were days where discrimination was very high, and it was very difficult for a young man or a young woman having a normal life, working, to actually explain to her or his boss that, I need half a day to actually go to the hospital, because that would immediately raise suspicion somehow. So we opened a clinic that was running from 6 p.m. to midnight on Wednesdays. That clinic is now 16 years old, and it's still going on. It was a very interesting experience, because on the one hand, that was bringing, allowing people to be in a sort of anonymous environment. They wouldn't have to explain, again, to miss work or explain why they would have to miss work. But at the same time, it was a unique clinic, because all people who were there sort of sitting together, waiting in the evening, and in the silence of the evening in a hospital. You can't imagine how silent a hospital is in the night and how noisy it is in the day. They were realizing, that they were all having this disease for which we have no treatment, and they would see from time to time how one of them would deteriorate, and that would, act as a sort of mirror on them. Anyway, Danielle Defer. Zaki Ahmad, some of you may have heard of Zaki, who is the leader from TAC Treatment, the Treatment Action Coalition in South Africa. That is an extraordinary movement, civil society movement. Françoise Barré-Sinoussi, whom I mentioned, this year's Nobel laureate, a very humble, extraordinary basic scientist who was actually the first person to see the virus, to identify the virus. And so when I think of these people, I come to my fourth lesson on leadership here, and the fourth lesson is that what all of these leaders in science and in communities have in common, I think, is to challenge acceptance of the status quo. They said that we cannot just accept or keep accepting things as they are always, as they have always been before. Because that we know that treatment works. We know that we can do something. We can just no longer placidly accept that a person living with AIDS in Africa, would be condemned to die, whereas a person living with AIDS in the U.S. or in Europe would live. Challenge acceptance of the status quo. No, act up, remember. So to summarize that sort of section of my remarks, that story came to me with, I sort of thought of four lessons. The first, the importance of evidence as a basis for advocacy and leadership. The second is the importance of humility and of the limits of medicine. This means accepting that rarely within one's own field or discipline is one possessed with all the answers. And this is particularly true, and this came particularly true with AIDS, because it's a disease with such complex social dimensions that has so much to teach us all. Third, it's the extraordinary leadership of patients and of people with diseases in general, as you prepare for leadership in global health, in actually formulating the responses themselves. And fourth is as I said, the importance of challenging acceptance of status quo.